Hi guys, today we'll see about ectopic pregnancy. Now before diving into the topic proper, we'll discuss some basics. So we all know about menstrual cycle. On day 14, when ovulation happens, the primary for oocyte will be converted into the secondary oocyte, and the follicle will be converted into the corpus luteum. So on day 14, a hormone called LH will be helpful for the release of this corpus luteum. It will be on a if a non-pregnant woman is there, this corpus luteum will be degenerated in the absence of fertilization in case of a non-pregnant woman. But in case fertilization happens, this will be converted into the female pronucleus, and along with the male pronucleus, it will be converted into the zygote, which is followed by implantation. If the implantation is happening outside that of the uterus, that is a proper uterus, we call it as a ectopic pregnancy. Now, this corpus luteum, which is degenerated in a non-pregnant state, will be surviving in the pregnancy because of the hormone HCG that maintains corpus luteum. This corpus luteum will be present till the 10th week of gestation in a pregnant woman maximum, and after 10 week the corpus luteum will be degenerating, and the function of the corpus luteum will be taken over by the placenta. Now, this particular process is called as placental luteal shift. What is the basic function of the progesterone? So, progesterone is secreted by corpus luteum till 10 weeks. After that, it switches to the placenta. This progesterone basically does decidualization of the uterus. So, for example, if implantation happens, this uterus will be this uterus endometrium will be no longer called as endometrium. It will be called as decidua. And this decidua will be divided into decidua paritalis, decidua basalis, and decidua capsularis. But in case of ectopic pregnancy, the decidua is not divided into such names and called as decidua vera. There is no capsularis, paritalis, basalis. Generally, we call the decidua as decidua vera in case of ectopic pregnancy. On ultrasound, we'll find a pseudogestational sac present in ectopic pregnancy. So, what basically happens is the decidua will not be supported enough in the ectopic pregnancy, and the decidua will be shedding in the form of blood. So you will be having a doubt. In case of ruptured ectopic, there can be bleeding per vaginum. But why in case of unruptured ectopic, there is bleeding per vaginum? It is because of this residual cast. Okay. Now, before moving on further, we should be knowing about the paths of the fallopian tube. So, the fallopian tube from medial to lateral. So, if this is the fallopian tube, the medial most part is called as the interstitium, and then isthmus, and then ampulla, and then the fimbrial end. So basically, you are from medial to lateral, interstitium, isthmus, ampulla, and fimbrial. If the fertilization happens in the interstitium, we call it as a most dangerous site for the ectopic pregnancy, because if implantation happens over here, it will be supported by the myometrium, which is very dangerous. And the duration of pregnancy will last more and does more damage. Now, what is the most common site of ectopic pregnancy? So, the most common site of ectopic pregnancy is the tubal or non-tubal. In tubal, we have the four parts, as I mentioned. In non-tubal, we have implantation on the C-section scar, implantation of the cervix, implantation on the ovary, implantation on the abdomen. Anything can happen. So, we'll first discuss about the tubal part. In tubal, the most common site is the ampulla. Why it is more common in ampulla? Because fertilization happens in the ampulla and the mucosal fold, we call it as plica, is maximum in the ampulla. The least common site is interstitium. But you have to recall that interstitium is the most dangerous site for the ectopic pregnancy as it is supported by the myometrium. What is the most common non-tubal site? It is the ovary. What is the least common site? Least common site overall is C-section scar, followed by cervical ectopic, followed by abdominal ectopic. Overall longest time, overall we call it as abdominal ectopic. Most common site for tubal rupture is this isthmus. Most common site for tubal abortion is ampulla. So we have certain criteria for non-tubal ectopic. For cervical, we have Palman's criteria. For abdominal, you have Studiford criteria. For ovarian, you have Spiegelberg criteria. You just remember these names. No further information needed on this. Now, moving on to the risk factor. Most commonly, it is pelvic inflammatory disease or salpingitis. Why now? Why this is a most common risk factor? Because when adhesions are formed due to the PID or salpingitis, when adhesions are formed due to the salpingitis, the ectopic will be implanted in the tube itself. What are the other risk factors? If there is previous ectopic, cervicitis, multiple partners, smoking, previous C-section, infertility and assisted reproductive techniques, and contraceptives. Now, multiple partners is a risk factor because it is also a risk factor for PID. Smoking is a risk factor because smoking reduces the motility of the villi in the fallopian tube. Now, moving on to the contraceptives. Contraceptive decrease the absolute risk of the infection, that is the ectopic pregnancy, but it increases the relative risk. What do I mean by this statement? So, contraceptive as a whole will decrease the normal pregnancy itself. So, as ectopic pregnancy also, it decreases the risk. But if failure happens, then the risk of developing ectopic is high. Clear? Now we'll talk about progesterone a little. Progesterone is a smooth muscle relaxant. Progesterone containing contraceptives have high chances of ectopic. I'll explain this both. As progesterone is a smooth muscle relaxant, progesterone will affect the movement of the fertilized zygote. Okay, so there are high chances of implantation into the tubes. So, which contraception is higher risk for developing ectopic pregnancy? That is, first is the tubal ligation, followed by progesterone IUCD, followed by copper IUCD, followed by progesterone only pills, followed by oral contraceptive pills. Now coming to the clinical features. We have a triad of we have a triad of amenorrhea, pain in abdomen and bleeding PV. The pain in abdomen is the prominent feature. The pain is lower abdominal unilateral localized pain. In case of unruptured ectopic, the pain is due to the stretching of the fallopian tube. The nerve root is T11, T12, and L1. In case of ruptured ectopic, it is due to the hemoperitoneum. Patient may even complain of mid-upper abdominal pain in case of ruptured ectopic and shoulder tip pain and urge to defecate. Shoulder tip pain is called as Danforth sign. Why the shoulder tip pain occurs? Because of the hemoperitoneum which irritates the diaphragm. And urge to defecate, the collection of blood into the pouch of Douglas compresses the rectum. So it causes urge to defecation. Now we'll move on to ruptured ectopic. Along with the triad, history suggestive of this is shoulder tip pain, urge to defecate, and orthostatic hypotension. General examination, patient may be in shock, and urine pregnancy tests will be positive. Perabdominal examination findings is abdominal distension and rebound tenderness. If the localizing signs as guarding and rigidity is present, then the management of ruptured ectopic is done. If the localizing signs such as guarding and rigidity is absent, we'll be doing fast ultrasound and we'll find if whether it is ruptured and do the surgical management of ruptured ectopic. Well, the management in case of ruptured ectopic is surgical only. If the vitals are stable, we'll be doing laparoscopy. If it is unstable, we'll be doing laparotomy. What is the surgery? It is unilateral salpingectomy, removal of the ruptured tube. In ruptured ectopic, there is no role of medical management and expectant management and any other surgery. There is a single line management that is unilateral salpingectomy, that is removal of the ruptured tube. On pervaginal examination, there is cervical movement tenderness due to peritonitis which occurs both in case of PID and ectopic pregnancy. We can differentiate this PID and ectopic pregnancy by using urine pregnancy test and beta HCG. Now the uterus will be smaller than the period of gestation. Remember, one investigation in ruptured ectopic is culdocentesis. This is the bladder, and this is the vagina, and this is the rectum. And the green colored thing is called the pouch of Douglas. We'll introduce a needle from the posterior fornix of the vagina to pouch of Douglas and withdraw some blood. If the blood in the syringe doesn't clot, then it is hemoperitoneum. If it clots, you have entered a vessel instead of pouch of Douglas. Now we'll move on to unruptured ectopic. So the same triad, amenorrhea, spotting PV, and pain abdomen. If these three are present, obviously the next step will be urine pregnancy test to confirm whether it's an ectopic pregnancy. In 99% of cases, UPT will be positive. And a negative UPT doesn't rule out unruptured ectopic pregnancy. This is why, because when implantation occurs, the syncytiotropoblast formed will be interacting with the decidua to form HCG. This is the basis of the urine pregnancy test. But in case of tubes, there is no proper implantation. If there is no proper implantation, there are chances the UPT may be useless in 1% of cases. In such cases, we'll do TVS. In TVS, if you see gestational sac plus yolk sac, it is diagnostic of unruptured ectopic. You have to manage it medically. It is a diagnostic. If TVS show gestational sac without yolk sac, it is not diagnostic. In case of Doppler, there is ring of fire appearance due to increased vascularity, empty uterus in TVS, complex adnexal mass, areas of hemorrhage. It is not diagnostic. Next, you have to measure serum beta HCG level. Now, moving on to the HCG part, there is something called as critical titer. Critical titer is a value that is basically if 2000 international units for TVS, that is we are doing in TVS, if there is 2000 international unit, gestational sac should be present in the uterus, in a normal intrauterine uterus. So we'll measure HCG. If the value is greater than 2000 international unit, that is above the critical titer, then it is an unruptured ectopic because greater than 2000 international unit, gestational sac should be present in the uterus. If it is not present in the uterus, then obviously it is an ectopic. If we have less than 2000 international unit, means it is an early intrauterine pregnancy because in early intrauterine pregnancy, the levels of HCG is not as much as high. It can be an ectopic, it can be a non-viable intrauterine pregnancy, which is abortion. So you have to repeat the test after 48 hours. If the value nearly doubled, that if the value is, for example, 100, if it is nearly 200, it is a live intrauterine pregnancy. If the value increases less than 33%, if 100 and it's 125, then you can confirm it is an ectopic pregnancy. This 100 I'm using for example. So if the HCG value is decreasing, if 100 then it is 75, if it is decreasing, then it is an abortion. The gold standard investigation is laparoscopy. Other investigation is serum progesterone value. If it is greater than 25 nanograms per ml, it is a live intrauterine pregnancy. If it is less than 5 nanogram per ml, it is a suggestive of ectopic. Contraindications is hysterosalpingogram, HSG, hysteroscopy, colpotomy. Colpotomy is used for draining of pelvic abscess. These are contraindications for ectopic. Even normal pregnancy, these are contraindicated. We will not perform this in a pregnant woman. Management option. You have medical, surgical, and expectant. Medical management is the best. If prerequisites are not fulfilled, then we'll move on to the surgical. What are the prerequisites? Unruptured ectopic with family complete. We'll do surgical management. If vitals are stable, HCG is less than 5000 international unit, size of the ectopic is less than 4 centimeter, cardiac activity should be preferably absent. Note here, if cardiac activity is present, it is not a contraindication to medical, but there are increased chances of failure. If patient also insists to do medical, then you have to do medical. If the size of the gestational, that is the ectopic, is less than 3.5 centimeters. What is the medical management? That is drug of choice is methotrexate, given intramuscular Dosage is 50 mg per meter square or 1 mg per kg. Methotrexate injection is ectopic is a single dose therapy. In case of GTN, we give multi-dose therapy on day one, alternating with folinic acid. Now, as we are discussing for ectopic, it is single dose therapy. So, you have to inject methotrexate on day one and you have to measure HCG and you have to repeat this on day 4 and day 7. On day 4 and day 7, you have to measure HCG. If the levels on the day 7 and day 4 should be decreased. What I mean is, I'll be clear, level on day 7 should be greater than 15%, less than day 4. I mean, if on day 4, if the value is 100, it should be at least 85 on the day 7. There should be a drop in value from day 4 to day 7. Okay. If the drop is less than 15%, if 100 and it's 87, in case this drop is less than 15%, then the dose is not sufficient. You have to repeat the dose. But can we repeat it infinitely? No. Even after 3 injection of methotrexate, that is the maximum value, maximum time you can inject. Even after 3 injection, the fall is less than 15%, or on any time the HCG increase between day 4 to day 7, then we consider it as a failed medical management. We'll move on to the surgical management. I'll explain with case. On drug 1, if you are injecting methotrexate and you have 10,000 international unit HCG, on day 4 to day 7, there is an increase. If there is an increase, what I've told you, on any time HCG increase between day 4 to day 7, it is failed. So it is failed. On case 2, if you have injected on day 1, it's 10,000 international unit, day 4 has 8,000, and day 7 is it's decreased, but decrease is less than 15%. Now you have to repeat on case 3. Day 1 is 10,000. On day 3, you don't have to measure in day 3. Day 3 is 11,000. If the patient taken on day 3 and they panicked as the value is increasing, so you might think the treatment have failed. No, it is not. This is normal value that can increase between day 1 and day 3. I told to test it on day 1, day 4 and day 7. Between day 1 and 3, there will be an increase in HCG value because the shrinking sac of dying ectopic release human chorionic gonadotrophin. Now surgical management, if the family is complete, the same salpingectomy. If family is not complete, then the option is incision on the ampulla with hydrodissection without closing. If closed and sutured, there will be adhesion formation, and the adhesion formation will be lead to the another ectopic. Are you able to get? Now this procedure is called as linear salpingostomy. That is incision with hydrodissection without closing. The obsolete surgeries are salpingotomy and milking of the tube. These are not useful. Role of expectant management. Prerequisite should be HCG value should be less than 200 international unit. Value of HCG should be spontaneously decreasing. No gestational shock should be visible on ultrasound. In case of heterotrophic twins, this is an extra edge point. If one is intrauterine and one is ectopic, you have to manage it surgically, not medically. What is angular pregnancy? It is a normal intrauterine pregnancy. For example, this is the uterus. If the pregnancies happen near to the cornua, it is called as angular pregnancy. It is not an ectopic pregnancy, it is a normal intrauterine pregnancy. What is cornal pregnancy? Cornal pregnancy is a ectopic pregnancy in interstitium. It is an ectopic pregnancy. Or you can have in the rudimentary horn of the unicornuate uterus. That is also called as cornal pregnancy. How can you differentiate cornual versus angular? If pregnancy is medial to the round ligament, if this is the uh, pregnancy, if pregnancy is medial to the round ligament, it is called as angular. That is normal. If pregnancy is lateral to the round ligament, then it is cornual. Okay, we'll just summarize it on exam keywords. What is the definition of ectopic? Any pregnancy that is outside of the uterine cavity. What are the types? We can classify this into tubal and non-tubal. Tubal, we have four sites. Non-tubal, we have on cesarean scar, we have on cervix, we have on ovary, we have on abdomen. What are the risk factor? The most common risk factor is PID. PID, smoking, multiple sexual partners, contraception, ART. What are the clinical features? That is the triad: amenorrhea, abdominal pain, bleeding PV, and the additional clinical features in case of ruptured ectopic is pain on shoulder, urge to defecate, and shock-like features, orthostatic hypotension. How we can diagnose it? Diagnosis can be made on UPT, beta HCG values, and transvaginal sonogram, and TAS even. What is the management? Management is surgical in case of ruptured, and medical, surgical, and expectant in case of unruptured ectopic. Finally, landing onto the complication. What are the complications? Tubal rupture, shock, hemorrhagic shock, and then we might also have infertility. These are the major complications. Okay, that's all for today. Thank you.